Welcome. This is Dr. Nettleman bringing you For Your Health. We have the privilege today to have Dr. Paul Wasson, ophthalmologist. Paul, this is your second or third time.
I've been on a few times.
On a few times. It's
topics.
been a few years, maybe 8 to 10 years. And you're over with Eye Health, New England Eye Health.
Eye Health Services.
Eye Health Services.
Right, exactly.
And you've recently changed your location, I understand.
Correct. We moved our office from Route 18 down to Libby Parkway in October, and it's worked out very well.
And your surgery center still is on Route 18?
Exactly.
Right. Very good. Easier parking and all that sort of thing for the regular patients. We're going to talk today about cataracts, and when patients come into you, they don't come in saying, I've got a cataract I want fixed. I mean, how do you go about finding out about the cataract, about the difficulty with vision, and discussing this with the patient?
Yeah, you bet. Cataract surgery and cataract evaluation really centers around visual function in a patient's daily routine. And so patients generally, when they have cataracts that are operable, that are considered for surgery, have blur in their daily routine. So they generally present with a complaint of visual blur, be it driving at night, reading, watching TV. And then basically we do a complete eye exam and determine that the cataract is the source of visual loss, ruling out glaucoma, macular degeneration. So it's with an exam and a history from the patient. If the visual blur bothers the patient enough in their daily routine, they are a candidate for cataract surgery. So cataract surgery is really patient-driven. It's not surgeon-driven. Okay, so a United Airlines pilot landing big jets in the rain would probably be operated on a little sooner than someone who no longer drives at night. So we tailor our decisions on if it bothers the patient enough in their daily routine.
Does it affect your ability to read, find things, watch television?
You bet. There are different types of cataracts. And reading, probably the most difficult visual things we do are reading and basically driving, and then watching TV. The new scrolling on TV has brought a lot of people in earlier because they begin to not see they can see the TV but not the scrolling. So those are the visual demands that generally are affected in a patient's daily routine.
I see. I remember years ago they used to talk about a cataract being ripe.
Right.
What does that mean?
You bet. And this is a great way to think of cataract surgical decision making. Years ago, that would be in the 1950s and 1960s, where we did large incision cataract surgery. The surgeon would actually come in and look at the cataract and make a surgical decision that if it was thick enough to safely remove. And so you might have it back in the 50s and 60s, you might be blurry, but he would say this cataract isn't ripe enough to remove. With modern technology, which now spans 30 odd years, we can really remove any cataract technically with equal risk. And so the issue of ripeness, meaning me looking at the cataract and telling the patient it's time, has gone away. So ripeness is when the patient's bothered in their daily routine.
So as you say, it's patient-driven.
Totally.
Totally. Very good. Okay. Well, what sort of discussion do you have with the patients? I mean, the last time you were here, I think you only touched upon the fact that there were lenses that could be replaced that affected astigmatism or improved this or that. The patient had a choice, and I think there was a cost factor too.
Exactly.
How has that changed?
Yeah, so basically what we should talk about today as far as an update in cataract surgery is basically discuss, and this is a lot of patients have questions now in that there's now a choice for intraocular lenses. And we should probably, let's back up a little bit. And so what we want to do with the program is talk about intraocular lenses. But let me start off by saying that cataract surgery is basically a two-step process. One is removing the cloudy cataract, and then the second is replacing the lens, which has become cloudy, and I'll show you this on the eye, with an implant, which we call an IOL, or an intraocular lens, in the eye that serves the purpose of your natural lens before it became a cataract. So let me just do a little anatomy here. This is an eye as it sits in your head. And if we open it here, the eye is very similar to a camera. And basically, the light rays come here. The first refracting surface is the cornea. The light rays are gathered here, and then behind the cornea is the lens. And the lens of the eye, the cornea and the lens of the eye bring light rays into focus. All the orange seen in this little model is your retina. And the center part of your retina, which is your macula, serves your central vision. So the front of the eye acts a little bit like a camera, focusing. The back of the eye, the retina, think of it as film in the camera. In cataract surgery, the lens of the eye actually becomes opaque for reasons we don't understand. The protein structure of the lens is normally transparent when we're born, and as we go through life, and it's generally, when we don't know what it is, it's age-related. The lens of the eye has disorganization of the lens proteins, which basically makes the lens cloudy. So the light rays come through the cornea, hit the lens, but they don't get to the back surface of the eye, and that's what creates blur. So in cataract surgery, what we're doing, and we'll see a little short video in a minute, but we're basically taking out the cloudy lens and putting an implant in. Okay, so that's a brief anatomy lesson. And so when we talk about intraocular lens, choices, and with LASIK, which has come on in the last 15 years, we have a surgery that can eliminate the need for glasses. LASIK is much more precise than intraocular lens technology at this point. But you'll hear people talking, I had my cataracts done and I barely need my glasses. And so what we do when we decide to do the cataract is you're cleared by your medical doctor, Dr. Nettleman, and then the second thing we need to do is measure your eye for the power of your implant. And if we just look at this briefly again, and without boring you with optics and stuff, we basically, everyone's eye has a particular corneal contour and a particular length. And so when you're ready to have your cataract done, you come in, we do a topographical map of the cornea, which describes its curve, and then we measure the length of the eyeball, and then with formulas, we determine an intraocular lens power for you. Okay, so when you're getting set to have this done, you have some pre-op tests, which is an ultrasound and corneal topography. And from those numbers, we determine, and the implant that we put in has a power. And so then we need to have a discussion with the patient. What do you want to be after cataract surgery? And so we generally, in probably 99% of patients, set the implant power for good distance vision. And the expectation that we convey is that when we do that eye, you'll have very good uncorrected distance vision, but you'll need reading glasses. And a lot of times if we do one eye and then the other, you have cataracts in both eyes, people have fairly good uncorrected vision at distance, and then they just wear the over-the-counter reading glasses at near. And so not only they're delighted with the fact that their vision's better, but we've reduced the dependence on glasses. Now, this is not a throw away your glasses proposition. In other words, the implants that we pick are in half diopter steps, and astigmatism, which we'll talk about with these implants, can be corrected fairly precisely. And we'll talk about those implant choices. But we always describe it as there will be a residual need for glasses after your cataract surgery, because we want to basically under-promise and over-deliver. And so in thinking about it, we want to decide, and sort of before we get into decision making, why don't we show this surgical clip that'll actually show the tail end of a cataract surgery. We're not showing you the whole cataract surgery, but us inserting the lens, and then I'll show you what this implant looks like. So if we could have that. So on the screen there, we just removed the majority of the cataract, and that bright orange reflex is actually your retina through the operating microscope. So we make this through a small incision, and this is called small incision cataract surgery. The incisions now are about 2.75 millimeters, very small. That's why you generally don't need to wear a shield at night, and you can resume your normal activities. These instruments that we put in, and you can see just in the tail end, we're removing the final bit of protein or the cataracts under the iris, which we call the equator. And so once the cataract is totally out, we prepare the eye for the insertion of the implant, which we'll do. The other thing that's coming up as a decision point is what anesthesia we use. We use Versed, so you're very, very relaxed. So as you look at this, you're not feeling any of this. And we either use drops or an injection around the eye. The topical drops are the more important. Now, you'll see the implant here going into the eye. This is a little injector, and we wiggle it in there. And then you'll see this lens come out. It's like a taco. And then basically, as it comes out, you'll see that little edge there. And then the optic power, that circular thing, is the implant power with the power that was designated for you. So this second half is the insertion of the implant. I think that's good for the video.
Very good.
So it's cataract out, implant in. Now, when we talk to patients, there are 3 different types of implants that are presently available. One is called monofocal, which basically in English means it has that implant, which I'm going to show you here. This is much bigger. The implant that we put in, probably the diameter of the implant is a little bit bigger than the eraser on a number 2 pencil, just to give you an idea. But this implant, just to show this model, it has little tiny haptics that actually expand in the eye. That's why we don't have to suture the implant. And then this is the power of the implant. And we can set it for farsighted, meaning good distance vision, or nearsighted. So the first choice is, and what we do most of the time, is we set the implant for good distance vision. Now there is a person who might, if they are an avid reader and they're not a driver and they really value their natural vision, their natural nearsightedness without glasses, we can set the implant power for the reading distance, but there's no free lunch. They have to wear driving glasses, okay? And so the majority of the time, and particularly, we set the implant for good distance vision because as we go through our 60s, 70s, 80s, 90s, our retinas don't dark adapt quite as well at night. You're relatively fine, but we want to sort of yoke both implant powers so they work together. And the distance is probably best for night driving, which becomes problematic anyway in our 80s and 90s. And then the other option on the power is to do one eye for distance and one eye for near. That's called monovision. The advantage of that, and it's good for a patient who has some particular need at near that's repetitive. And I often make the example of like a landscape painter, someone that might look in the distance to see the landscape and then have something at 24 inches, and this is not that precise, I want to emphasize, that he can then see the paint on the easel. Other reasons for monovision are people that don't really want to wear any glasses. Now, the advantage of that is you get some distance, some near, but a lot of times you end up needing glasses for driving at night to make the near vision participate in the distance. So the first choice in these implants is distance together, near together, or monovision. The majority of people, we advise listening to them, we probably do most of the time 2 eyes for the distance. Okay. So then, and that's called a monofocal implant. Now recently, and we're not on the bleeding edge of technology when we're describing this. This is 7, 8, 9, 10 years old, but we now have 2 other implant alternatives to talk about. So this implant that we set for distance has the monofocal. The implant companies developed, and as we talked, the power of your implant depends on the length of your eye and the curve of your cornea. Now, everyone thinks that astigmatism is a disease. You know, they come out of their regular eye exam saying, oh my God, I have astigmatism in my eyes. That is not. It's a description of the optical properties of your eye, which is that your cornea, which is the window of your eye, is not like a basketball. It has a short length and a long length like a football. And that little change is astigmatism. Now, the implant companies, to their credit, have developed intraocular lenses that we can put extra power in one meridian or the other, okay? And when we put this in the eye, we then rotate it so that the astigmatism is counteracting your corneal astigmatism. So the advantage of that, so that's the first one, is that it corrects your distance vision. It does not eliminate your need for glasses. This is where people start to get confused. And it is one that you have to pay for because Medicare doesn't pay for this new technology, which I'll totally outline in a minute. So
lens doesn't move once you put it in place.
Right, and so to the credit to progressive implant technology, the flaps around where we took the cataract out seal this in position. Now, never say never in medicine. They can move, if they move, they shift in the first week, and we take you back to the operating room and reposition it. That actually is very rare. It's not totally zero, but it's pretty rare. So these are actually fairly predictable. And so what you get out of that is good uncorrected vision. Now, astigmatism comes in all degrees, and everybody has a little bit of astigmatism in their glasses. Generally, I think the people that would benefit from this are people that they're the ones that wear gas-permeable contacts when they were younger because they couldn't wear soft contact lenses. Their eyeglasses look like funhouse mirrors. And these people know who they are. They spend a lot of time at the optician fiddling with their glasses. And so if you have a high amount of astigmatism, it's a good idea, I think. And the price of this implant, it develops up between practice to practice, but there's a range. It's sort of $900 to $1,500 per implant. Now, if you decide not to do that, you've not made a bad decision, okay? In other words, we put the residual astigmatism in your glasses. So the monofocal with your glasses is as good as the astigmatic contact without. So a lot of people are wringing their hands saying, geez, I want to do the best for my eyes. But when properly discussed, it's not inappropriate to decide not to spend the money, okay? So you just need to know that it improves your uncorrected distance vision.
And if you get the lens with the astigmatism correction, how close is it? Is it right on?
It's pretty close.
Yeah.
Now, it's not like LASIK, which we began this story, where we can actually laser the cornea down to 0.1 diopters. That's our units of refractive error. It's pretty close, but we do tell patients there may be a slight residual distance prescription, but it'll be, your uncorrected vision will be much better than if we didn't put the toric lens in. If that's not important and you've worn glasses all your life, don't spend the money.
Right, right.
Now the third choice is an interesting one that's come along, and I think that this is a technology that's in its growth. And so this is called a multifocal implant, which is, in the implant here again, the implant here, when it's monofocal, has one power for its entire surface. We implant companies now can do like rings of a tree. Your distance, you're near, your distance, you're near, your distance, you're near. So think of it, when people say, oh, this is a bifocal implant, they're worried they're going to not be able to hold their head right. This is a circle, okay? And so half the implant is devoted to your distance correction. Half the implant gives you near vision. So that is something that's good. Now, at this point, this is for someone with one perfectly healthy eyes. And the reason why I say this is that you can't have any early macular degeneration. You can't have any real dry eye because this implant is a light sharing implant. In other words, the problems we've had with it is when you go out at night, sometimes it decreases a second sophisticated measurement of vision, which is called contrast sensitivity. In some patients, night vision isn't quite as good. And that's a big problem because most of the time you're having your cataracts out to drive at night. So the light sharing part of this is a negative. Hopefully in the years to come, we'll be able to get a better optic that doesn't decrease your contrast sensitivity. Right. The second thing is this near part. There's a measurement here. You know how you go to the drugstore and you buy 250 readers, plus 250. Well, think of it as we can put a +2 in here, a +3, but you sort of have to pick your range. And so a computer person might have a +2, and a reader or a needle pointer might be a +3. So there's a decision on the reading part, right, which is not perfect. And so the way properly discussed, we tell patients, if you have this multifocal implant, you'll probably not wear glasses 80% of the time. So it's not a throw your glasses away. You may have a little residual distance you need to put on at night, and for different things at near, you may need a little help with a drugstore reader. So that's that. And the other thing is this is more expensive. I don't mean to sound like a car salesman here, but that's on the order of $2,000 to $3,000 an implant. And that is, we put very few of these in for those reasons. And across the United States, this whole issue of glare at night, and I don't want to make it sound like it's terrible, because some people, if they're really motivated to not wear glasses after cataract surgery, this is an option, okay? But across the United States, there's an explantation rate, meaning patients are unhappy enough with the multifocals that they have to have them surgically removed. And that's somewhere between 0.5 and 1%, which may not seem like a lot, but if it's you, it's a lot.
Right.
So,
what do they use in place?
So if you had a lot of glare and were not happy with the quality of your vision, it comes down to those discussions. Right. We put a monofocal in. And so it's not poison. It's very good for a small set of patients. And it's a technology that's really starting to develop. When it's as good as your bifocals on, yeah, we'll be encouraging this.
What do you expect to see in the next 10 years?
Oh, I'll tell you, I've really enjoyed a great ride with cataract surgery in that I think the implant technology is the big thing. The other thing is we're beginning to use laser in conjunction with cataract surgery. At the present moment, the laser-assisted cataract surgery is making the incisions. We don't have a laser yet that can actually emulsify or vaporize the cataract. So 10 or 15 years from now, I think we're going to have really small incisions, maybe none at all, vaporize the cloudy lens, which is the cataract, with a laser, and maybe inject an implant to meet your needs.
Yeah. Fantastic voyage. Very good. What is the average age that you see these patients with cataract surgery?
You think of cataract surgery as a Medicare diagnosis, and basically the majority of our work is in people over 65 to 70. However, we probably 5 to 10% of patients have cataracts in their 40s and 50s, and that's not a sign of ill health. Yeah. It's the luck of the Irish. We don't really understand what causes cataracts.
And these cataracts stay in basically for the rest of their life.
The implants.
Yes,
you
implants.
Bet. You bet. And so, and the good news is too, and that's a really good question. You know, how is there a warranty on these? Yeah, basically they are very, very good. We use silicone and acrylic, which are plastics that are very well tolerated. We're so confident in these materials now, we put them in babies with congenital cataracts.
Excellent. Well, Paul, Dr. Wasson, I'd like to thank you again for coming. You've given us a very interesting talk, and I hope with too many people didn't get queasy with it. But again, I thank you, and good luck at your new location. And you've been doing this for how many years now?
Yeah, I'm getting old. I've been at Eye Health for 28 years.
28 years, very good.
Thanks for having me.
You're welcome. And this is For Your Health. Dr. Nettleman, I hope you've enjoyed the program. Thank you for watching.